Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN, Healthy You, Healthy Nation, Healthy World. I'm Nancy Valentine, PhD and registered nurse, and this show is dedicated to you, the healthcare consumer. And one of the goals of this show is to transform healthcare policy into people speak so that you as the consumer will really understand some of these changes. And we have a really excellent guest with us today, a renowned expert in healthcare quality, and let me introduce you to him. Dr. Paul Grundy is the director for IBM's healthcare transformation work. He is also president and director of the Patient-Centered Care Collaborative, which is located in Washington, D.C. Dr. Grundy has a tremendous background. He has been the winner of the National Healthcare Quality Award in 2012. Now, that's a very notable award. Past winners have included Senator Kennedy and the governor of Pennsylvania, former Governor Rendell. He has also been known as the godfather of the medical home, and we're going to find out today what that means. He is a graduate of the Medical School of the University of California, San Francisco, and he trained at Johns Hopkins University. Dr. Grundy, it is a distinct pleasure to have you with us today. You're an internationally well-known person, and to be here in Wayne, Pennsylvania, speaking with us today, I'm sure we're going to learn a lot from you.
Well, Dr. Nancy RN, it's a pleasure to be with you, and you have such an amazing reputation for the transformation that you help drive in our Veterans Administration, for example, that I'm so proud of. As a nation, we've really made a difference in quality in organizations like that, and I'm just delighted to be with you and chat with you about a concept of how we're going to transform the model of delivery.
Thank you very much, Dr. Grundy. You know, I think one of the things that we're going to learn about today, and Dr. Grundy is really going to give us some of the facts and some of the examples that he has seen on a national scale in terms of, you know, what is going to change in healthcare and what are the kinds of things that you're going to see. So in this show, we're going to talk about the unsustainable cost of healthcare, which I'm sure you're very aware of. Also, how data, the things that we are collecting to really understand better how healthcare is delivered, we're going to speak about that. And then we're going to talk about changes in communication and how you can more effectively have a conversation with your treatment team so that you have a better understanding of healthcare and your participation in that. So, Godfather of the medical home, enlighten us about what's going to be coming down the road.
So when I talk to patients about the kind of care they want for themselves and their family, I mean, they really want a healing relationship with somebody that they can trust, and they want access to that relationship, and they want to be able to communicate in a profoundly different way with that relationship, and they really want help in maintaining the kinds of impetus and quality of what needs to happen to make a difference in their lives. I happened to have moved about 8 years ago to the Hudson Valley from Minnesota when I changed jobs with IBM, and we took our cat to the veterinarian. And our cat, within a few months, got notified that it needed its immunization. I went to our primary care provider in the community and I said, how many women in your practice are 65 and over? And how many of them have been notified that they need their breast exams? And he looked at me and he said, frankly, Paul, I don't know how many women are in my practice, let alone how many are 65 or over. Mm-hmm. And I mean, we now are in a medical home in the Hudson Valley because we've been driving that transformation. You know, it probably saved my wife's life because she was notified that she needed a breast exam, and she got detected early and treated early. So it's as simple as that. It's really as simple as thinking about, you know, what is it that really impacts a patient? What do they really want? I was recently called by a colleague here in the Philadelphia area asking about the fact that they had a problem and couldn't get in to see their doctor for 2 weeks. I said, I think you need a new primary care doctor. Mm-hmm. And fortunately, here in the Philadelphia area, there's been a huge drive around building medical home with support of the healthcare plans like Independence, with the support of the state, with the effort that they've had in the chronic disease initiative here in the Philadelphia area. So I was able to actually direct them to a place near their home. Joe Mambu, a medical home provider here in the area, got in to see the patient that day. The patient got in to see the doctor. And the patient was calling me and saying, my lab results are on my cell phone before I got to my car, right? So you're beginning to see that understanding that you can communicate more effectively, you can engage more effectively, that somebody's going to follow up and follow through with your needs, and you're not going to let things slip through the crack.
But most people that would be watching this would be saying, well, I go to my primary care physician, I'm reasonably satisfied. What is this whole idea of medical home? Does that mean that my doctor or my primary care provider, maybe a nurse practitioner, they're going to change their title somehow? I mean, what is it that people would even know that they're going to see someone that's involved with a medical home?
I think that without sort of asking, you might not know. But a medical home is one in which you as a human being are valued. There is mechanisms in place where you really have access and where you really have a profound relationship with your healer. So here in the Philadelphia market, you have hundreds of practices that are en route to do that. I recently visited one on 9th Street, which is led by nurse practitioners. And there's that healing relationship. It happens to be with a nurse practitioner, which is great. But it could be your primary care physician. But the other thing that's really important about a medical home is it's moving from a single person doing everything to a team. So in a medical home environment, you have your care that's being coordinated. That's oftentimes done by a nurse. They probably do that more effectively than a doctor does. Oftentimes you have care education folks. So you begin to think about what it is you need to do to help a diabetic stabilize their diabetes. What are the skills you need? How do you need to use a pharmacist to do medication management adherence? Those kinds of thought processes go into that transformation away from selling an episode of care on a hamster wheel that the docs have on, into the docs beginning to be paid for outcomes of how well they manage their diabetes. I can tell you that I visited a practice here in the Philadelphia area in the last year or so where we have literally had a 60% reduction in the complication of our diabetes. That's 60% less amputations. That's 60% less blindness. That's 60% less people ending up on dialysis, right? I mean, that profoundly changes somebody's life.
That's really true. That's astounding and should be replicated everywhere.
Absolutely. I mean, that's what we should be trying to buy, right? Rather than a focus on, how do we rescue somebody, who needs an amputation? Unfortunately, the delivery system, as it's currently structured, handsomely rewards for that amputation, but doesn't reward as well for preventing the person from needing the amputation. So, from the standpoint of buyers of care all over the country, they're increasingly saying to the delivery system, stop already. We don't want to see the sign anymore that says we deliver the best heart surgery. We want to see the sign that says we manage a population, we manage it so well that there's 1/3 less of the patients who need heart surgery.
Right.
And by the way, when we do heart surgery, we do the best, but that's not the focus. The focus is away from, an episode of care towards managing a population in a profoundly powerful way to begin to get at that. And we're seeing that happen.
Right.
And right here in Philadelphia is one of the early national demonstrations that Medicare funded, called the Medicare Advanced Primary Care Model, that has actually shown some pretty significant results in terms of reducing the number of folks who end up in the hospitals and end up using emergency rooms unnecessarily. That's a huge savings for people, for humanity, right? In terms of just suffering, let alone cost.
Well, I think there are a couple things that you said that I'd like to clarify in terms of buyers of care. Often the patient thinks that they're the buyer of care, but that's not the buyer that you're talking about.
So the patient can be the buyer of care, and increasingly they have a higher percentage of the cost of that. But in this country, the actual percent of money that's spent is broken down almost equally between government and large employers.
Right.
And so, I mean, if you happen to work for a large employer, you oftentimes are lucky enough to have a health care plan which is partially funded by the large employer. Oftentimes those large employers are self-insured, right? So most large companies, you think of a health care plan as who's paying the cost, but it isn't. It's your employer.
Right.
And by the way, that comes directly out of your labor cost, right? I mean, you have not, as a citizen of the greater Philadelphia area, received any increase in your salary statistically over the past 10 years because all that has gone to increase cost in health care.
Right. So I think it's really good to know that the buyers of care, the large employers, for instance, and even some smaller employers, are really asking those hardball questions, and such as, what are your outcomes? Certainly, if we've heard that there's a clinic or a system that is giving care where there's 60% less complications of diabetes, everybody wants to go to that clinic or get care at a similar place, or really have everyone move up to that level of care, because that's the kind of care that's going to make a difference. So also another point of clarification, can this medical home be beyond primary care? Can it also be for specialty care?
So the basic concept of a medical home is a place in the system where you have a healer who is a comprehensivist, right, who manages comprehensive care. Mm-hmm. So a specialist would oftentimes manage a part of the body, okay, right? So from the standpoint of the patient, from the patient's standpoint, whoever is working on you, whatever it is you need, is part of your medical home.
Right.
It's the patient's medical home. It's not the doctor's.
That's a very important point. Now, I know a lot of people get involved with concierge medicine, and I just think it's important for you to make some differentiation, because a lot of people have made investment in concierge primary care. So how does that work together, or is that separate from a medical home concept?
So in a delivery system where the primary care physicians are paid per episode of care, many physicians have sort of rebelled against that and said, I really want to deliver this kind of model where I manage a population, I have better relationships, I can see less of them so I can spend more time with them. And so oftentimes in frustration, they have shifted the charge away from the employer to at least partially to the individual. Mm-hmm. That is known as a direct care model or a concierge model of care. We're seeing that emerge, and I think for many patients it's worth the effort and the money to do that. But I think the concept of buyers insisting on this happening is that we're basically saying that level of care that you can buy yourself, we want to buy for everybody.
Right.
That should be the level of care that should be available, to our mothers that are covered under Medicare, to our neighbors who are covered under Medicaid, to the person who's lucky enough to have an employment model of care and is covered by their employer. But it should be the standard of practice for every practice that everybody in that practice gets this level of care.
Right.
And it makes economic sense.
Right.
And it makes economic sense because, again, when you really begin to use the tools of a care coordinator, a nurse coordinator, patient engagement with adherence, compliance, little tools like I saw in Joe Mambo's practice, this little kiosk called Care Partners Plus, which was so cool because the patient walks out of the doctor's practice, they go up to this little Welby's thing, and in a 1.5-minute survey, it begins to give the patient information back about what is it they understood or didn't understand in that encounter, and then it follows them home to their computer or to their cell phone, and it reminds the doctor that you just had 15 minutes with this patient, and this patient doesn't understand what it is. So, so we see a 20-30% increase in patients actually taking their medication when they begin to get these reminders,
right,
systems to do that, little tools that make it easier for the doc and the patient to do the right thing.
But a lot of those tools are the ones that you're mentioning are really centered around patient education and patient understanding of what their role is and what their medications mean and what they need to do as a follow-up to the encounter. Now, is that the kind of thing that people are going to start seeing in their encounters with their healthcare provider? They're going to see more education. They're going to see nurses talking to them about coordinating their care.
Yes, I think in the medical homes we're seeing that increasingly. In fact, what's happening is that here in the Philadelphia market, the healthcare plans are actually paying for care coordinators to be placed in practices to follow up and follow through, and so is CMS as a buyer in many markets. So you're beginning to see the value of the nurse case manager, the nurse care coordinator, the patient educator, the pharmacist as a team member to really begin to engage across an understanding of the fact that, you take a patient and you think you're going to throw a dart, right? And that patient's going to take their medicine and we know better than that, right? You're throwing a bird.
Right.
And when you throw the bird, it flies. Between, when you let it go and what you want to have happen. And there's a whole science around how do you begin to really empower with tools and resources and follow-ups and reminders, patients actually doing what they need to do. How do you empower them with benefit redesign, for example, to really have, some impetus to engage in wellness programs?
Right.
I mean, I've seen many exciting new programs where a little pedometer is hooked up to a cell phone, and if you do your exercises, you get little nice reminders that kind of encourage you to do that. But you also get a real decrease in your cost of your benefits if you do it right. So you begin to get the patients engaged around doing the right thing rather than a $20 copay.
Well, I think it's such a shift in thinking, and it's certainly not subtle, because just going back to your point where a physician would typically give direction or write a prescription and sort of expect that the patient would follow up and follow through, whether they understood it or not. Their expectation was that they would just do what they were told. And when they didn't, patients were basically labeled as non-compliant. And they were really given a label that was rather negative. This is a whole much more positive approach, because not only are you giving people tools and prompts for education, but you're giving financial incentives that if they do follow up and follow through and get engaged in some of these health and wellness programs, they will actually have some money come back to them.
That's right. I mean, you really want to incent the patient to do the right thing. You want to incent the doctor to do the right thing. So you stop paying the doctor only fee for service, and you begin to pay him for outcomes, right? So all of a sudden, it's in the doctor's interest to help you better engage with your team to take your medicine, because you're going to be rewarded on how well you manage a population, and no longer rewarded exclusively on just doing an episode of care. And by the way, that's what the doctors have been asking for. They gave us a set of principles they call the joint principles of the patient-centered medical home, and they said, let's change the covenant between what you buy and what we provide. Let's pay us to do the right thing. Let's help the patients do the right thing, and we'll all have a better delivery system. And unfortunately, you have hospitals in this market that have, 12% margins that, are doing quite well on a model of, if we fill up our beds. I mean, those days are going to end, because they're not sustainable in terms of a cost structure that we have in our delivery system.
Well, it sounds like the money will shift from just the inpatient care, which is very expensive and can derive a fair amount of profit, in large volumes. But those dollars will be shifted more to the outpatient and more to developing these medical homes and accountable care organizations, which is a whole other discussion, to really help people more on a grassroots level to deal with their illnesses more effectively in partnership with their treatment team.
Yeah, and I think that it isn't a whole other discussion, actually. I mean, accountable care has to have as its foundation a medical home. Let me explain that to you. So what you really want to have is robust primary care and prevention in a place of a healing, trusting relationship with your healer, right? And then held accountable.
Right.
So if you're going to have data, and by the way, we just spent $18 billion getting that data from the meaningful use from the technology of the EMRs that are going to roll out, right? All the data is going to be beginning to flow. Well, if you're going to have data, where are you going to put it, and who are you going to hold accountable? The interesting thing about data is that every other industry, banking, retail, insurance, when data occurs, there's an expectation you're going to be held accountable to that data.
Right.
And for the first time in healthcare, we're going to have data. We're going to understand whether or not, a patient and a doctor relationship is adding value to the system or not adding value to the system. And, there's going to be an expectation that we're going to begin to pay against that now and stop paying for fee-for-service.
Right.
You see, the basic model of care that we've had in this country is one in which evolved, at the end of the last century, the scientific method, the Flexner model of care, in which we use bright medical students. We use them as data storage repository units. They store information. As the information became more and more complex, we specialized further and further to be able to store them in unique devices, because nobody could store it all. That era has ended, right? All of a sudden, you now have the data that the medical students aren't being trained as data storage repository units anymore. They're being trained to think about you as an individual, and how do I put a plan around you? How do I design, a system where I understand what your genetic information is, I understand other information now, because I have that information, that data, I don't have to store it in my head, it's there in a computer. And how do I put a plan around you in which I really look at the best way to reach you and your needs it could be quite simple, right? For a healthy individual, it could be a wellness program and immunizations. For somebody with diabetes who's complex, it could be very complex. But a plan around everybody, just like engineering process. So, we went from building a cathedral with a master builder with information in their head to an engineering process where we build a skyscraper. There are people on the team that understand the tensile strength of steel, that understand wind forces, right? That's what's happening in healthcare.
Right. Do you see all the physicians jumping on board with this? I know that you said there was a whole cadre of people that are obviously the movers and shakers, said, we want this whole new system to revolve around the patient. But I think that when you go into some of the doctors' offices, they're all very good, very well-meaning, but they look some tired, beleaguered at times, feeling like they're on a treadmill themselves. So how are they going to be able to, in large numbers, make this transition? And what's going to help them to be successful?
It's fascinating when I go into practices around the country because, particularly the primary care docs, they feel pretty exhausted,
right?
Because increasingly they've had to see more and more patients. Right. The amount of time that they have to see the patients, so they complain bitterly about that. It's kind of like having a discussion with a spouse, or with a marriage counselor about leaving a spouse that's beating you, and then the other spouse says, "But I get 3 meals a day." I think
it's hard to get off the treadmill.
Hard to get off. It's hard to get out of the rut you're in. There's a huge culture shift that is occurring, that has to occur, and I think, frankly, the hardest culture shift is really, for the first time, healthcare is faced, like every other industry, with a thought process of how am I going to get more efficient? How am I going to use tools like Six Sigma and Lean? How am I going to ask myself today, how do I improve my practice today, right, for tomorrow? That isn't something that we've traditionally done in healthcare.
Right.
And so the concept, right, of moving from everything is stored in my head and I direct everything centrally as a master builder to I have a team. And what I focus my time on is 2 things: difficult diagnostic dilemmas and relationships. And the rest of my team does everything else.
Right. Well, that is a big shift. But I think the other part of the equation are the patients themselves, because when you were talking about some of these new prompts, people getting information at home on their computer or on their smartphones, I'm thinking of some of the older folks that are really not using all those tools on a daily basis and have had a very traditional relationship with their treatment, either team or person. They may really only think it more as a person, one particular person. How are they going to be able to adapt to all this? What's going to happen?
They love it. Older people are oftentimes some of the earliest ones to adapt some of these. It's fascinating. And you see them doing that as partners, oftentimes doing that as partners with their children. Many people who have health difficulties as they reach senior age, are a bit dependent on the next generation down, if they're lucky enough to have somebody help them with that. And so, I've seen that happen all over the country where this is moving pretty fast. north of you, in further north of you, up in the Geisinger region, I mean, this is pretty far along. And even here in some practices, this is pretty far along. I mean, Joe Mambu is a geriatrician, and his patients are connected. I mean, and many of them will love getting online and looking at their data. It's quite interesting. My mom is 91, and she uses Facebook, right? I mean,
so people are adapting and adopting the technology. So where do you see this going? I mean, you said that you started this program, many years ago, really getting it ramped up. Now it's sort of becoming front and center for the general population. Where do you see this moving, and how fast do you see it moving?
So first of all, the concept of the patient-centered medical home, or the concept of the medical home, really goes further back than anything I started. There was a Chinese pediatrician in Hawaii that first coined the term in the literature. I guess I'm known as the godfather because I've just kind of pushed for this to happen and be available to our lives more than the concept. It's become the standard of care in the Veterans Administration, as you know. It's called patient-aligned care teams there. It's the standard of care in the DoD. It's now the standard of care that the largest employer in the United States is asking for, the Office of Personnel Management, which is the federal government as an employer. It's become the standard of care for the largest healthcare plans. So WellPoint, United, Cigna, Humana, they're all driving in this direction. And the reason why they're doing that, of course, is because they have to, because of unsustainable cost.
Right.
I mean, when you see data like I just described to you of 60% reduction in amputations, I mean, absolutely. So WellPoint, for example, bought CareMore, one of these practices that does that level of care, and they're rolling it out across the country.
That is really impressive. So the players in this, with the insurance companies, the payers really making a very major change in this. Do you think the provider community can make that change rapidly enough? I mean, where do you see that evolving?
So I think it's a journey. There are some places that are further along. I mean, here in this area where you've had some pilots going on for a few years, you really have some concentration occurring. An example that I recently visited was Michigan, where I would say about 80% of the providers are in a medical home. North Dakota, it's 100%, but there's like 3 out there. Small state. But the point I'm making is that when I go out and I look at this transformation occurring on the ground, and I see some of the places that are the furthest along, I still think they're about a third of the way there.
Yeah.
I mean, this is a journey.
Yes.
I mean, this is a journey. And I think that, I think it really needs to start with you, the patient, the consumer, fundamentally asking yourself the question, if I needed to see a doctor today, could I get in to see my practice?
Right.
If I wanted to access my primary care provider, could I email him and get an answer back in 24 hours? Is there a mechanism where my lab results, my information is available to me online so I can look and follow up? And if that's not happening to you in this market where you have access to it, you should begin to think about either talking to your primary care provider about doing it or finding one that does it.
I think that's really great advice, and I really like to use the last moment or so of our show to really think of that through. I think that what Paul's given you is permission to ask some of those questions that you may or may not have even thought of asking, such as, can I get in? What's the access? I mean, do I have to wait? And you don't necessarily have to be part of a concierge medical team in order to do that. You may not have had to buy up to that level of care. That he's telling us that is the expectation for all primary care providers, that you can really be seen immediately, within some reasonable period of time, which is not necessarily days or weeks. I think the other is, are you getting education? What kind of education is being provided to you? Education is very different than just being given a list of tasks. Like you have to go to the pharmacy and get your medication, or you have to go for a lab test, or you have to go to a specialist for a consult on something. Education is really understanding your illness and what is causing it, what you can do to really benefit from taking some action so that you will, have your illness better controlled and prevent any further deterioration in your problems, how to get your family members involved. So that's really the psychosocial piece of it, who's going to help you at home. So it sounds like, there's a lot more out there that you could be getting from your visit. And what did I leave out?
I think you covered it really well. And when you look at communities that are a bit further out, right? I just visited St. Johnsbury, Vermont, and they've taken 1.9 cents out of every sick care dollar by legislation. They've created a community care organization run by nurses, care coordinators, social services, and they literally wrap a plan around every patient. So it isn't just your primary care doctor and their team. It's a community coordinator that looks across all the social services agencies. They meet once a month. Mm-hmm. They talk about how they're going to support every patient. I sat in a room in one of those meetings, and an Episcopal priest, a young lady, spoke, and she said, in St. Johnsbury, we are never, ever again going to allow a diabetic to have an amputation. It isn't going to happen in our community. You know, if they need support with Goodwill Industry, if they need support from their church, if they need support from social service agencies, we're going to find that support, and we're going to wrap it around that patient. We're going to make sure if a patient wants exercise, there's a trail to hike on. I mean, you begin to think about this.
That's very impressive.
Yeah, there's a great film that ARC, I'll send you a copy of it. Maybe you can show some clips of it, but that ARC produced around the St. Johnsbury experience. And that sort of thing, I think, is beginning to roll out. Again, 1.9 cents out of every sick care dollar goes to create community coordinators that look across the entire community and wrap a plan around every patient.
And give many more support services.
That's right.
Well, I think in closing, I want to thank Dr. Paul Grundy for being with us today, because I certainly have learned a lot from his experience and his vast opportunity to go around and sort of see where those exemplars are across the United States. But the kind of change that we've talked about today also begins with you. So I think that this is your invitation to really ask for more, to expect more, and to have a better life. Thank you very much for joining us. I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening, and join us again. And remember, with health, all things are possible.